Now, please welcome with me Dr. Mohammed Algamdi. He's a consultant in pulmonology, critical care, and interstitial lung disease at King Fahd Medical City in Riyadh. He will be talking about the global guidelines on managing IPF. Please welcome Dr. Algamdi.
Thank you for the opportunity. So before we go over the guidelines of IPF, we will just shed a light about the main trials that have formed our treatment of idiopathic pulmonary fibrosis. And as you can see, although the idiopathic pulmonary fibrosis is a chronic disorder and it is not uncommon, unfortunately, the studies that have made the way that we treat IPF right now have only started to show up in the last 20 years. So if you look at the first trial that was of value, it was only reported in 2005. This is very different from what we see in the other chronic disorders like heart failure, liver cirrhosis, etc. Now, when we zoom in into the most important studies that have informed our decision making, Iphigenia trial was published in 2005, and it had two arms. The first arm was N-acetylcysteine plus prednisone and Imuran, and the other arm had prednisone and Imuran alone without N-acetylcysteine. In that study, the group of patients that have received N-acetylcysteine in addition to steroid and Imuran had a lesser decline in their FVC and DLCO. On that basis, the same group of authors have published Panther trial in 2012. And on that study, the authors grouped the patient into three groups. Group 1 had placebo alone as a treatment for their IPF. The second group had N-acetylcysteine alone. And the third group had N-acetylcysteine in addition to prednisone and Imuran, similar to what happened in the Iphigenia trial. In this trial in Panther, and after the recruitment of the first 60 to 80 patients, they had to discontinue the trial because of harm that was induced and inflicted upon the patient. There was an increase in the mortality, so they had to abandon the study. And from that time on, the anti-inflammatory medications are no longer treatment option for patients with idiopathic pulmonary fibrosis, except in the cases when there is an exacerbation, and that is a different topic. They actually continued the two other arms of the study, the N-acetylcysteine versus placebo, and on that arm that was an extent of Panther trial, the study revealed that the addition of N-acetylcysteine, or the arm that contained N-acetylcysteine versus placebo, did not preserve FVC and DLCO over time. So at that time, N-acetylcysteine was also removed for the treatment of idiopathic pulmonary fibrosis. Now, the basis of the use of N-acetylcysteine was the mechanism of N-acetylcysteine that is presumed to limit cells injury. When it was tried on IPF patient, it did not work. So the first hope that we started to see was in 2011, when the two phase 3 trials of IPF were conducted, Capacity 1 and Capacity 2. Unfortunately, the study resulted in mixed result. Both of the studies were multinational. One study was positive and the other study was negative. So the FDA mandated the same group of authors to actually conduct a new study. Tomorrow study in 2011, same year, was the study of nintedanib efficacy study, phase 2, not phase 3. It was like a dose finding, efficacy finding kind of a study. And it showed that this treatment, which is nintedanib, is safe to use, and it slows the disease progression or the decline of FVC over time. It was an efficacy study, so no recommendation was made by the American Thoracic Society regarding nintedanib at that time. And in the same guidelines, they recommended not to use pirfenidone because of the mixed result. In 2014, the Impulses 1 and Impulses 2 were conducted. Both trials were concurrent multinational studies using nintedanib in one arm versus placebo in one arm. And that study was positive, showing modest effect in reducing or slowing the disease progression over time. Ascent trial was the answer of the authors to the FDA when they mandated the authors of pirfenidone to repeat their study. So they conducted the Ascent trial, and they finally showed that there was benefit of adding pirfenidone to patients with IPF in terms of slowing the disease progression over time. The group of authors that conducted Tomorrow and conducted the Impulses trial gathered all the data, and in 2015, they published a reanalysis of the combined data, and the benefit of nintedanib remained there and remained positive. So these are actually the studies that informed our decision making in IPF. And if you compare this with any chronic disorder that you know about, this is really a scarce, like limited number of trials and data. So there is only one comprehensive global guidelines. It's led by the American Thoracic Society, and it is published in their documents or their papers. It is a conjoint effort of the American Thoracic Society, the European Respiratory Society, the Japanese Respiratory Society, and the Latino Respiratory Society, or the ALAT. So they actually have a group of authors or experts from each society, and they form a conjoint guidelines. In 2011, at the time of the first trials of antifibrotic medication, they released their first IPF-specific guidelines. In 2015, they gave it a general update after the conduction of the phase 3 trials of pirfenidone and nintedanib. They gave an update about the diagnosis of IPF in 2018, when we started to use cryo biopsy, and when we started to use multidisciplinary discussion in making the diagnosis of IPF. And in 2022, they gave their latest update to the guidelines of IPF after we had more experience with cryobiopsy and more experience with MDD diagnosis of IPF. So this is the 2015 statement, and at that time they gave a conditional recommendation to use pirfenidone in IPF patient, and a conditional recommendation to use nintedanib, and that was the first time that there is an established antifibrotic treatment for patients with idiopathic pulmonary fibrosis. In 2018, they made a diagnostic procedures recommendation, and they divided the patient into the group that had UIP pattern on CT scan and the group that had the other patterns of CT finding in IPF or ILD patients. And the patients with UIP, they recommended, or they suggested not to do PAL, and they recommended not to do surgical lung biopsy or cryo biopsy because the diagnosis is already there. In terms of the patient who has no UIP but other patterns, they suggested to do BAL or bronchoalveolar lavage, and they did not recommend for or against the use of cryobiopsy or transbronchial lung biopsy because the cryobiopsy at that time was just started. The yield was not as good as now, and the side effect profile was huge. The risk of bleeding was up to 40%. The risk of pneumo was close to 40%, and the risk of bleeding is close to 15%. For both patients, the patients with UIP and non-UIP, they recommend a thorough investigation, as my previous colleagues mentioned, and connective tissue disease workup, and a multidisciplinary discussion to make the diagnosis of IPF versus the other conditions. And since that time in 2018, the multidisciplinary discussion diagnosis of IPF and ILD in general has become the standard of care. In 2022, they have updated the previous statements, and it was a focused update. They specifically mentioned that cryobiopsy now can be regarded as an alternative to surgical lung biopsy in the patients who have ILD with undetermined etiology. And this is because of the improved yield over the years and the better safety profile with these procedures. They also suggested not to treat IBF patients with anti-GERD treatment or PPI for the sake of improving their respiratory symptoms, because there are actually no strong evidence to support that. They also suggested not to refer your IBF patient for anti-reflux surgery for the sake of improving their respiratory symptoms, because again, there are no finding that supports doing so. If your patient has symptoms of GERD or has radiological findings or scope findings of GERD, go ahead and treat. If not, you don't treat. They established or adjusted the different CT patterns in the description for it, and we have already gone through that in previous lectures. And they did not make any changes to the histopathological patterns of ILD. So this table is derived from the 2018 statement. They just put a specific update to the pathway of diagnosing IPF in 2022, which is the inclusion of probable UIP as a very close pattern to UIP, and in certain conditions, it is enough actually to make a diagnosis of IPF based on that probable UIP pattern. And they specifically said that if the clinical setting is right, and you have a probable UIP, and the ILD MDD team agrees that the IPF is the most likely diagnosis, go ahead, forgo biopsy. The post-test probability of diagnosing IPF, if you happen to do a biopsy, is above 80%. They specifically said that the right clinical setting is having a patient who is male, who is above 60, who is a smoker, who has GERD. So you have to have the right clinical setting. If you have a probable UIP picture, but the patient is female and her age is 50, that doesn't work, right? So don't take it easily. Having a probable UIP doesn't always mean IPF. You have to have the right clinical scenario, right? The risk factors are there. The patient is male, the age is above 60, the patient is smoker, etc. The Fleischner Society group of authors in their white paper, they actually gave a better description to this right clinical setting. And they specifically said that the patients are above 60, they have no exposures of interest, either occupational or environmental, and that they have no connective tissue disease symptoms or sign. It was a clear description to this right clinical setting. So if you have it and you have a probable UIP, and the group of experts during the ILD round thinks or believes that the diagnosis is IPF, you call it IPF. If your patients have exposure to farm, like a hay, moldy hay, or he has a bird, and the age is like 58, and the patient is male and has probable UIP, you are not supposed to call it IPF, and you're supposed to do further investigation. Now, this table is only gets into practice when you have both histopathology and radiology. Otherwise, it is of no use. The only thing that I would like to make a clear statement about is what to do when you have the light green color diagnosis, which is suspected IPF. When you have suspected IPF, there are certain features that if you have, it will elevate or upgrade your diagnosis from IPF, from suspected IPF to definite IPF, and this has already been clearly defined in the American Thoracic Society statement. So if the bronchiectasis is moderate to severe, that's one sign that elevate the diagnosis from suspected IPF to definite IPF. If the patient age is above 70 and the extent of fibrosis is more than 30%, then that also elevate the diagnosis or increase it or make it definite instead of suspected. If the patient has no lymphocytosis in bronchoalveolar lavage or increased or abundant neutrophilia on bronchoalveolar lavage, this also makes the diagnosis definite instead of suspected. And if the ILD group of experts during the ILD MDD round group of experts believes that the diagnosis is actually IPF, this also upgrade the suspected IPF diagnosis and makes it a definite IPF. They also described the patient journey in terms of diagnosis and then surveillance and treatment. We are not going to go over that because we have already done that. Beside the global IPF guidelines, there are some local IPF guidelines. There is actually no much difference in terms of the recommendation when you compare it to the global one, and that's because of the scarcity of the evidence to support the generation of guidelines. This is the CPAR, the IPF guidelines of the Spanish Society. This is the British one made by NICE, and this is the South Korean one, and these are just examples. We have more than that, and thank you very much.